All right, guys, I just wanted to kind of reach out to you. I know we got a lot going on with COVID, and so we wanted to put out a little bit of information. We have a video here. It's pretty good from FlightBridge. However, it's pretty in-depth. So I want you to watch that video first, and I want you to go through it. It talks a lot about pathophysiology, gives you some really good information. And then I want you to watch this video, and hopefully between the two of them, we can understand what they're talking about. FlightBridge is talking about all kinds of things: type 1 and type 2 pneumocytes, inflammatory mediators, macrophage cells, release of cytokines, and interleukin 1 and 6, and what does all that mean, and how are we supposed to treat these patients, right? So there's vasodilation. It's going to happen. We got these cytokines out there. Our lungs have interstitial fluid. Our alveoli are filling up with fluid. We've got all kinds of issues, even in so much that we also have cellular swelling. We have problems not just in the lungs, but all throughout the body, right? So what are we going to do? And we're talking about the bad patients. Not everybody with COVID-19 is going to go this far, but talking about these patients that are critical, that we have respiratory problems. First of all, Dr. Gus has made it very clear we are not supposed to be doing any kind of neb treatments in the ambulance. So if you have to do a neb treatment, do it inside, distance yourself at least one room, but the preference is to avoid neb treatments. We can do BiPAP. That's fine if we want to go BiPAP. Make sure we're using the vent tubing. We put exhalation ports on the exhalation tubing. There's a contraption, a little bit of tubing here that goes on these exhalation ports. There's a little bit different ones. This is a stopgap until we get some newer ones in, but it's going to work for now. We're trying to knock down that virus, making sure it's not coming out. But we can use BiPAP, right? So that is an option. Think about what's going on, though, what FlightBridge is talking about here, what's going on with the patient, what's going on with their alveoli. So we're getting lots and lots of fluid buildup inside the patient, inside the patient's lungs, right? And so we're trying to get oxygen in there. We're trying to get good gas exchange. And so it's twofold. We don't just have fluid in there. We also have the breakdown of the gas exchange process. We're not holding open those alveoli. We're not keeping recruitment. So what are these patients going to need from a ventilatory standpoint, whether we have BiPAP or we intubate? The preference on these patients is to intubate earlier. And obviously we're using all of our PPE. We have our gown on, we have our mask on, we have our glasses on. We're doing everything we're supposed to be doing. But if we have to intubate, we can. We're going to be running high PEEPs. So you're like, oh, Nick, well, I normally run 5, right? 15 over 5. We may be running 10. We may be running 15. The patient I had the other day, we were up to 18. We were able to back that off over time, but we had to get up to 18 to achieve oxygenation. So like we talked about in all of our trainings, Ashley's been talking about this, I've been talking about this, we're starting that FiO2 on the vent at 100, taking out one part of the SpO2 side of the equation. So we're going to start that at 100 on the FiO2 side. If they're not oxygenating appropriately and we're in pressure mode, we're going to start to increase that PEEP. So maybe we started off at 5. We might go up to 10. We might go up to 15. We might go up to 18. We're going to have higher PEEPs. Just remember, your PIP has got to go up when you increase your PEEP. That way we got enough room to get some volume in. So your PIP might be 10 over whatever your PEEP is. It's a kind of a good rule of thumb. So if you get your PEEP up to 18, your PIP might be 28, okay? That's okay. We're going to watch our tidal volume, but we're going to have to run high PEEPs because what we're doing, we need that pressure to get the air in, and we need that pressure on the PEEP side to keep the lungs open. So that's kind of the ventilatory strategy. We're going to really be trying to make sure we keep recruitment of the lungs, keep the alveoli open, get the air in, and keep them open. But that's only one part of this rather large equation, and that's what FlightBridge is talking about here. It's not just about oxygenation. We get that part, that's great, but there's a circulation component. These patients are going to present like sepsis patients. So we can't just look at one side of this coin. We have to make sure we have good blood pressures and that we have good circulation. So we got to look at what the heart's doing. We got to look at that blood pressure. We're going to need to get fluid. And you're like, I can't get fluid, Nick. I just took care of the fluid buildup. No, you're right. We're taking care of the fluid buildup with our BiPAP or a vent. You still need to give fluid to get into the vasculature, okay? So we want to give fluid, make sure we have a good blood pressure. We may have to go down our leave-a-fed route. Remember, fill the tank before you squeeze it. We might have to give them some fluid, a good full bolus, leave-a-fed to get that blood pressure up. We have to make sure the oxygen is getting from the lungs all the way down to the cellular level. The only way we can do that is if we've given a good fluid bolus and we're working that side of the coin. We're going to want to watch our end tidals. Some of these patients are very alkalotic, i.e. they have a low end tidal. We have to ventilate them appropriately. We need a good goal minute volume, and they talk about that by Flight Bridge too. Minute volume is not just something Nick made up. Minute volume is a real strategy at ventilating our patients. So going for a good goal minute volume, making sure we have good gas exchange, higher PEEPs, higher PIPs, and then making sure we have good circulation to get this around. The body in the end stages or later stages of this, and this progresses quickly, has a complete body inflammatory response. Now, we aren't going to get into the medications that the hospital is going to use. We're talking about the pre-hospital treatment, and it is solely focused on making sure they have good circulation and good oxygenation. The only way we're going to get good oxygenation, running higher PIPs and higher PEEPs. I strongly recommend you use pressure mode whenever possible with these patients. There's the rare case where you might have to switch to volume mode if they're just so filled with fluid that we can't get any volume in, but that is a rarity. So plan on pressure mode, plan on high PIPs and high PEEPs. Call me if you have questions. Call Ashley if you have questions. Call one of your BCs, whoever you're most comfortable talking to. Guys, the other part of this, you cannot watch one of these videos once a month or do the once a month training and be good at the vent. You're going to have to do other things. And so these podcasts are a great way to do a little bit of extra digging to make yourself better at the vent. And you don't have to be an EMT or you don't have to be a medic. You can be an EMT and be doing this research because that's the only way we get better. Seeking out information is what makes us better at our job. Guys, stay safe, keep it up, and we'll try to do more of these videos to help you out. Thanks so much.